We lead active lives in BC. That's why your BC physiotherapist is trained to work with you on virtually any mobility issue, so you can get out there and enjoy your life. Look for a PABC member at hospitals and clinics and movingforlife.ca. And keep moving for life.
I want to thank all you guys for coming here. You know, it's I'm always humbled by people that want to sort of hear more about something that I've been so passionate about for clinically and now academically for the last clinically for the last 16 years and academically really for the last 7 years. It was quite a journey, the PhD process, but it, you know, to see it validate what we knew clinically was effective. And that we saw with our own eyes, but that we can support now with some science was very rewarding at the end of the day. I also want to thank PABC for hosting me and these lecture series. I think, you know, they do so much to support and promote our profession in the province. I know I've been a member since day one and proud to be one, so if anybody isn't a member, sign up now. And also I want to thank Dale, Harris, and SportMed and Paris. I mean, they've, as we all know, they're such great supporters of our profession and professional development in the Lower Mainland. So thanks to them. So without further ado, I will introduce to you this is really, the first part of this was really the basis of my thesis defense. And then what I'll do is sort of progress into the application of the same technique in terms of our treatment of you know, the recalcitrant sort of chronic lumbopelvic hip conditions that I'm sure a number of you have heard me speak about before. You know, it's just Celebrini, the one-trick pony. But like I said, there may be a few twists in here, and like I said, even going through this process allowed me, being immersed in this for 16 years, really understand it at a deeper level. So hopefully I can share that with you. And I do want to save some time at the end to have a, you know, real sort of collegial sort of exchange of ideas and information, and I think that's what we all enjoy as well. So you'll be tired of listening to me by the 45-minute or hour mark, and then we'll get into that. So the application of it used to be novel. I don't think it's as novel anymore, soon to be novel as it's published, but movement strategy in decreasing the biomechanical risk factors for anterior cruciate ligament injury. And as I mentioned, as a brief overview, I'll provide some of the background and the purpose for this thesis. We'll go sort of stepwise through the different studies, starting with study 1, in which we tested the reliability of the biomechanical variables that we investigated, the outcome measures. Study 2, which was primarily a feasibility study, and then progressing on to study 3, which was a randomized controlled trial. I'll finish with some concluding remarks and try to synthesize things, and then we will explore some of the applications of this movement strategy in the treatment of, like I said, these lumbopelvic hip conditions. Excuse me. Anterior cruciate ligament, or ACL injury, is one of the most common and debilitating knee injuries in sport and is typically managed by surgical reconstruction and extensive postoperative rehab, as we all can attest to. An estimated 250,000, sorry, I'm a little bit behind here. An estimated 250,000 ACL injuries occur every year in the United States at a cost of over $2 billion. Young women participating in four-directional sports are much greater risk, 4 to 6 times greater risk than their male counterparts. And unfortunately, those that sustain an ACL injury are far greater risk for osteoarthritic changes. And this progression of arthritis or osteoarthritic changes is not slowed by surgery, unfortunately. So there are 3 prevailing theories to explain this increased risk of ACL injuries with these young female athletes compared to their male counterparts. And although anatomical and hormonal differences most certainly play a part, there's increasing evidence that the main reason for this gender difference is in how female athletes move in response to some of these high demands in sport. And fortunately, movement strategy is one of the few modifiable risk factors to these injuries. So high-risk movements in sport include, obviously, landing from a jump, which is common in basketball, decelerating quickly, and cutting to change direction, which is most common in soccer. Most injuries are non-contact. In fact, about 70% of these injuries happen without direct contact with an opponent. So really what it means is that these athletes are doing this to themselves. The ACL is ruptured when the strain produced within the ligament exceeds its tensile strength. And this is often observed in these non-contact injuries in sport when the knee is in a more extended position and the ACL is under increased load. An abduction or valgus moment, which is the force that produces this relative movement of the tibia away from the midline of the body. It's thought to be the most dangerous out of sagittal plane load on the knee and has been predictive of ACL injury in these young female athletes. Other body positions that have been observed at the time of ACL injury and that have been demonstrated they've demonstrated increased loading in lab-based experiments as well during side-cutting movements is this pattern of ipsilateral sort of side flexion and rotation to the stance leg, as well as hip abduction where the foot is in front and lateral to the center of mass. Therefore, effective strategies to prevent these non-contact ACL injuries during sport should influence how an athlete, should influence how an athlete avoids these extended knees, this abduction angle and load, try to minimize this foot in front and lateral to the center of mass, and try to avoid this side flex trunk and rotated trunk with increased neuromuscular control. So, that being said, a novel movement strategy at the time that we termed CORE-PAC, an acronym for core, position, and control, may address, at least we hypothesize, some of these risk factors. So the CORE-PAC includes a proximal to distal movement strategy, which is described here, and I won't read it out for you. But it essentially consists of first actively recruiting these core muscles and then pushing off the back leg so that the center of mass leads the movement in the intended direction. This assists the center of mass in getting over the stance leg as it's planted on the ground. And if we contrast this with a reaching or distal to proximal movement, wherein the lead leg reaches forward first, there's a leg of that center of mass followed by the push-off. So basically, they're just not pushing off that stance leg to the same extent. And a key part of this definition that will become more apparent down the line is differentiating a strategy. Strategy extends beyond a simple description of a movement pattern, and it includes how the learner organizes the motor, sensory, and perceptual information necessary to perform these tasks in different environments. So it's one thing for us to repeat a movement in the clinic. It's completely different if they have a strategy of movement, and then they can apply to different environments, contextual situations with opponents around them, different surfaces, weather conditions, et cetera, et cetera. So that was a really important part to the practical application of this. So the underlying rationale for the CORE-PAC is simply that it's a simple method of getting the center mass closer to the base of support with an increase in trunk control. That's basically the gist of it. That's what I spent 7 years doing, is investigating this. But this improved sagittal plane alignment with the hip, knee, and ankle in line may allow the muscles rather than the ligaments to absorb some of the kinetic energy coming up throughout the lower extremity, and may result in increased hip, knee, and ankle flexion angles. We can see the difference, the CORE-PAC on the left versus the reach on the right. And just on a simple agility drill, we can see how with a reach, there's little displacement of the center mass, that red ball in the middle. And the result is sort of that hip abducted and extended knee position, versus here where you've got the center mass going side to side and the center mass is consistently over that base of support. So you can see how the strategy within which this young athlete approaches the two quite obviously illustrates what we're talking about. So, content common to successful ACL injury prevention programs or prevention programs that have been effective in decreasing the incidence of ACL injury, presumably by changing how these athletes respond to those high-risk movements, have included strength, balance, plyometric power, flexibility, and technique. However, we still don't know the separate effects of these components and which ones might be the most effective at decreasing these biomechanical risk factors for ACL injury. Therefore, the purpose of my thesis and my doctoral work was to investigate the effect of this novel movement strategy in reducing biomechanical risk factors for ACL injury in these young female adolescent soccer players. And I was sort of hesitating, sort of providing all this information, but I think it's important because there were so many novel aspects to this work. We needed a stepwise approach, so I thought it was valuable to at least summarize the findings from all three studies so that you can really understand the methodology that we had to go through. So, like I said, in study one, we evaluated the reproducibility of these 5 biomechanical variables that have been identified as potential risk factors. So, again, I'm not going to go through the definition of reproducibility, but suffice it to say that at the end here, the fact, try that one more time. I won't click this time. The fact that there have been no previous studies that evaluated the reliability of 3D motion analysis for complex tasks like this side cutting to kick a soccer ball, this was a really important first step so that when we did go on to our subsequent intervention studies, we had confidence in our results that they weren't measurement error or just variability in how these individuals were performing the task. There's evidence out there to support unanticipated reaction tasks and more sport-specific tasks increasing forces at the knee. Therefore, we included these in our study design as well. Our subjects consisted of 10, 14 to 17-year-old club-level female soccer players that were, among other criteria, injury-free and were not presently engaged in any supplementary exercise-based programs. The subjects performed 3 tasks. This side-cutting task in which the subject starts in the stagger stance position, steps back to break a laser beam, followed by a step forward with that right foot onto the force plate, followed by a kick with the left foot into a soccer goal. The next task was an unanticipated side cut task, which is essentially the same thing, except as they broke the laser beam, there was a monitor to indicate whether they kicked the ball on the right or kicked the ball with the left. Both balls were kicked with the left foot. We only counted the side step to the left. That's the only one that we were interested in because it was the analogous to the side cut. So we discarded the cross cut ones, the ones that were kicked to the right, but it was important again for the unanticipated nature of the task. And then the side hop in which the subject hops from her left foot onto the force plate with her right foot and then back onto her left foot. So the mean values for the following 5 variables were measured twice, 1 week apart during the 3 tasks. Joint angles were measured throughout the stance phase, and then we looked at the first 20% of stance for the peak abduction moment. Each the subjects performed these tasks or the trials 9 times and had a work-rest ratio of 1 to 5. The kinematics or the joint angles were calculated with a 6-camera motion analysis system. We had 12 iRid markers on there to create a 3D model of the limb. And then we used 1 force plate that was used to estimate the forces and the moments at the knee using 3D inverse dynamics. So the results, again, I won't go through, but the summary of those results, those are sort of the details that you have within your slides. But the summary of the results is really that we found modest to excellent reliability and acceptable agreement for all but the peak abduction angle during the 3 tasks. So with all but that peak abduction angle demonstrating adequate reliability and agreement, we could have chosen really any of the other 4 variables. However, we chose peak flexion angle because it's the most reliable kinematic variable. And we chose peak abduction moment because it was a reliable kinetic variable in the frontal plane and because both of these variables have been identified as key biomechanical risk factors for ACL injury. So the next step in study 2 was to conduct a feasibility study. The purpose of this study was really twofold. Our main purpose was really to determine the feasibility of implementing the core pack within a warm-up. That was really important in terms of the practical application for this. And it was important to do this prior to regular soccer training. And we evaluated the feasibility based on subject compliance and how easily the core pack was integrated into the warm-up. the second purpose, if this thing clicks, was to determine whether the core pack would improve, obviously, the peak flexion angles and decrease the peak abduction moments at the knee during those 3 tasks after immediate instruction, after we first told them, or described the movement to them, and after the 4-week training program. So, subjects initially consisted of that same cohort of 10 club-level soccer players from Study 1, you can see here. The subjects performed the same 3 tasks. In fact, this was actually the same data set as the retest from Study 1, the initial test. And then after immediate instruction, the core pack strategy, data were analyzed, you can see here, for only 9 subjects due to the dreaded mechanical error affecting the data set from one of our subjects. So to improve compliance, which is obviously one of the main contributors or inhibitors to the success of these injury prevention programs, it's been recognized that such programs should be delivered within a team warm-up in less than 20 minutes, should ideally be soccer specific, and have little or no equipment. So those are all key contributors to the compliance, which again is absolutely critical that, that we have compliance if we want to really truly evaluate the effectiveness of these programs. Therefore, subjects were led by a physiotherapist, yours truly. I was, myself and my research assistant were sort of do everything as the process would dictate. So I would lead them through a 20-minute warm-up 2 times a week for 4 weeks, and then just right before their soccer practice, and then they repeated the same warm-up another 2 times per week on their own. The warm-up consisted of, as you can see here, core stability, balance, multi-directional running, which were already part of the players' regular soccer warm-up. However, they were instructed to perform all of these exercises using that core pack strategy. The 2 additional subjects that were lost here were, again, to unrelated injury. A little out of sequence there. So after completing the training program, we gave them an 8-item questionnaire to see whether they thought the program was effectively implemented and to provide sort of feedback on the utility of the core pack. What we found was that the core pack was effectively integrated into a team warm-up, that the subjects felt like there was adequate instruction and time to practice the core pack, and that they didn't perceive that there was any demand greater than a normal soccer warm-up, which is, again, important for us. There was very good compliance from the 7 subjects that did finish the training program, obviously low numbers, but interestingly, when asked, what did you find most difficult about the training, all 7 subjects chose the time to do it rather than the technique required or that it was physically taxing, which again brings home the point of how important it is that we recognize the team warm-up as this dedicated time to they're going to warm up anyways for these soccer practices, so it's a consistent time that they have available to them to get this done. Otherwise, the reality is some of these gym-based programs that require them to do this as a separate entity with busy parents and busy kids and school, etc. It's a really important part of this, and it's part of our initial queries. So here we can see this is a typical subject, and what we're demonstrating here is the change in both the peak flexion angle and the peak abduction moment for a side cut task. Here we can see the peak flexion angle at baseline, and then after the immediate instruction and after the 4-week training program, obviously the angles are increasing from top to bottom. And here we can see the baseline peak abduction moment and the decrease in that force at the knee, again, after immediate instruction and after the 4-week training program. So after immediate instruction, there was significant increases in peak flexion angle between 3.5 and 6.5 degrees, and significant decreases in peak abduction moments across all the 3 tasks. After the 4-week training program, subjects generally improved in both of these biomechanical variables across all 3 tasks, but we wanted, really here we were more interested in wanting to get an indication of whether the practical application of this had an effect, that it was, again, practically implemented, but that it had a positive effect on their biomechanical risk factors. So really this was an important sort of exploratory aspect of the study, and the observations in this context were encouraging, allowed us to move on to the next study. So compliance, again, being one of the greatest challenges for these injury prevention programs, the core pack appeared to be effectively implemented into the team warm-up without disrupting the flow or the physiological benefit to the warm-up. This ease of integrating the core pack into the athlete's regular preparation routine without additional time or equipment requirements and without interfering with the performance aspects and being soccer specific may well improve compliance. So the main limitation, obviously, with this particular study, besides the low numbers, was the absence of a control group. And without a control group, as we all know, that effect sizes can be inflated. So, and this in our particular study may have been a result of learning or practice effects or some of the other warm-up components, which we don't know what was the active ingredients in there. So, we concluded that the core pack was feasible, most importantly, and successfully implemented into a team warm-up prior to regular soccer training with good compliance and acceptance by the subjects, and that the core pack demonstrated improvements in these biomechanical risk factors after immediate instruction and showed improvement in some individuals after the 4-week training program. So, Study 3 builds really on the results of our exploratory work in Study 2. Specifically, this study addressed the main threats to our internal and to a lesser extent our external validity that were inherent in that single group pre-test, post-test design that we just talked about. So we wanted to control for those confounding effects of those extraneous variables. And this is obviously best done using a randomized control trial. So the purpose of Study 3 was really to use this RCT to compare the core pack group, trained group to a control group for these same two variables, peak flexion angles and abduction moments at the knee during those same three tasks after a 6-week training program. We hypothesized that the core pack group would have indeed greater peak flexion angles and lower abduction moments across those three tasks after the training program. These subjects were different level of soccer players. These girls were recruited from 2 provincial soccer teams and then randomized to either the intervention or the control group. Subjects' ages range from 14 to 16 years old and had the same inclusion and exclusion criteria as the previous 2 studies. Now, obviously, the most important change we made from Study 2 was in the study design. We started with 10 subjects in each group. We retested both groups after 6 weeks of training with the same instructions to use their own strategy to perform the tasks. However, we lost 1 subject, as you can see here, in the control group. We then retested both groups after reminding them to do the core pack strategy. That's obviously to the core pack group. The control group were retested using their own strategy. The same 3 dynamic tasks were used in this study. And the subjects in each group performed the same 20-minute warm-up program 4 times per week for 6 weeks prior to soccer practice, with the only difference being the instruction that the physiotherapist and the coaches provided to the groups. So the core pack was reinforced throughout the warm-up with cues such as move from the center and lead with the belly button. But this is really important. No other instructions were given to them, such as, bend your knees more, make sure your knee stays over your toe. Some of those classic explanations of safe technique. The control group was matched in terms of the frequency and the energy of the feedback, but they were provided with general feedback such as, keep your balance and good work and those types of things. So we tried to equate the groups in terms of that feedback. Compliance, again, was very good with almost 90% attendance in each group. And so after the training, the core pack group demonstrated a significant mean increase of 6 degrees or 10% increase in the peak flexion angle during the side hop task. And so again, this was them using their own strategy. Then, after reminding them to perform the task using the core pack strategy, there was a significant average increase of 8.5 degrees or 14% for the side cut task, and a 10 degree or 16% increase in the flexion angle during the side hop task. Now, what was interesting was there was no significant changes in the abduction moments in either group. This was disappointing. Even more surprising was the lack of improvement in the abduction moments in the core pack group after we reminded them to use the core pack strategy like we did in the previous study. We can talk a little bit about why that might be afterwards, but suffice it to say that was a big difference between the two studies. Having said that, the increase in flexion angles in the core pack group was a novel finding, and the fact that this was the first study to demonstrate an improvement in a biomechanical risk factor, that being the peak flexion angle, as a result of isolated movement training implemented within a team warm-up, which is, again, a really important part of this. And the fact that it was achieved within the rigors of an RCT provides us with additional confidence in our results. So we concluded that the core pack may be one method of modifying high-risk movements and supports the inclusion of a core pack instruction as part of a comprehensive ACL injury prevention program. So the limitations within this body of work were obviously a small sample size and large variance that left us perhaps prone to type 2 error. A limitation of all laboratory-based experiments is trying to infer injury risk with non-injurious movements in a controlled environment. So that's inherent in any design like this. And although we measured a core set of relevant biomechanical risk factors, there's others that we could have looked at the hip and the trunk and EMG, which was a frustrating aspect of the study. And finally, we don't know how well the positive effects that we observed might transfer to a competitive real-world sports setting, and if they are maintained at long-term follow-up. Those are really important questions that we have to ask ourselves in all these studies. It's great to see this sort of immediate effect, but is it being transferred, and is it lasting? So, despite these limitations, our findings provide some novel contributions to this area of research. We were able to demonstrate an improvement in one of the key biomechanical risk factors, that being knee flexion angle, after training a movement strategy in a practical setting on the field, with a team. So rather than some studies that have shown effectiveness using, individual training or video feedback, we, were able to demonstrate this in a very practical environment. The training effects were transferred without reminder to an untrained task, so that demonstrated transference of that strategy. And again, these at least, there was that greater than 1 week between testing and end of training to again demonstrate that transfer. So these were all important and novel findings, but the perhaps the equal or more importance is that this is a simple strategy with a single focus of attention. That appears to be easy to understand and perform for the athlete and monitor for the coaches. It's also potential soccer specificity and application these are all important considerations, again, when we come back to the compliance issue. So future directions, I think there's anybody that wants to do some research in this area, there's many areas to explore. The core pack, I think, quite honestly, should be evaluated and against and complemented by other existing instruction techniques. We must clarify the most effective ages, duration, instructions, and techniques to change these high-risk movements for ACL injury. We don't know that yet. We certainly need to investigate methods of technique modification in team settings with coaches implementing the programs. So, it's all well and good for us to stay in our bubble and look at the effectiveness, but are these positive effects being accomplished in a real practical setting? Because ultimately, this is where the battle gets won or lost. And future screening in terms of real-time feedback using markerless motion capture to evaluate and capture these movements on the field during training and games is really, I was going to say, an exciting future, but it's actually happening at present. And what will be interesting to see is the effectiveness of using something like the core pack in those particular arenas. So they say a picture's worth 1,000 words. This is essentially what sums it up. The picture on the right or our left is obviously something that we don't want to see our girls doing on a consistent basis, and to again, more consistently than not, get into that compact position with the center mass over that base of support. It puts a knee in a better position biomechanically. Interestingly, it puts it in a better position neuromuscularly, and it puts it in a better position in terms of withstanding any sort of perturbations in that position. So that part of things done. I'll just provide the acknowledgements to my committee members, to my lab assistants and members, to the participants, parents, and coaches, and to the funding agencies that helped provide the resources to conduct these studies. And there's your reference list. I'm going to segue into the next part. I'm assuming because of the podcast, we should continue on with this and then leave the questions either to the first part of this lecture or the second part till the end. So, with sort of that scientific grounding, we'll proceed and perhaps and hopefully stimulate some thoughts and some considerations in reestablishing athletic movement is really what we're talking about here, optimal athletic movement, and how we found it directly applied to the treatment or the rehab of these chronic lumbopelvic hip conditions. You know, it's often, and especially within this room, I think we could all recognize and agree that it's often the process of subjecting sort of new clinically effective techniques to the rigors of science that are often the most valuable, and certainly this was the case. And this is what really fueled my academic pursuit was the initial clinical effectiveness of this. So on we go. We're all very familiar with this diagram demonstrating this vicious cycle of dysfunctional movement, perhaps resulting from injury and then potentially contributing to further injury risk. One of the most important but subjective areas right now is how we describe, how we evaluate, and how we correct movement. As described, the CORPAC may be but one of the methods to assist us in this task. And as we've demonstrated the value that the CORPAC strategy may have on lower extremity biomechanics, as mentioned, the strategy was born out of the treatment of these recalcitrant lumbopelvic hip conditions. And I'm just going to play a video here to demonstrate the difference. Here you see that distal to proximal movement strategy where the lead is with the foot or the lower extremity. And you can see that the lower extremities are in a sort of extended, vulnerable position. And here we have the CORPAC strategy, basically, again, initiating the movement from the center, making sure the center mass gets over that base of support. So the same end result, the foot's going from point A to point B, but with a different strategy. And the strategy is such that the core area, this lumbopelvic hip complex, is active. It's not an effect of the movement, it's the cause of the movement. And it's really, again, it's that push off, that drive, and that compact position on landing. And you can make up so many different permutations and drills, but the fundamentals of this remain the same. And you can just see, see the lumbar extension, see the stress for a lot of the sports hernias that we see through here, that sort of cross pattern for some of the labral issues versus when they get that sort of firing around. Any effective rehab program must obviously respect these classic stages of healing as we've demonstrated here, and this guides obviously the conventional stages of rehab, which combine at different stages of the rehab process: strength, balance, stability, etc. But what we're going to focus on here is this continuum of functional movement that can and should be addressed in parallel with these. So I think quite often us as therapists, we want to get obviously the acute phase where you want to get things settled, but then right after that we're quite often looking at restoring range of motion or strength or isolating things where, and not to say that that's not a necessary component of things, but why not start then with that functional movement? Why not apply it even in its very early stages, if appropriate, if the condition warrants it? So to be consistent with the above, arbitrarily, if we developed 3 stages and within those 3 stages we looked at reinforcing and evaluating position, progressing to dynamic movement, and then sport integration. So in stage 1, and this is really important, is that this is a very motivating component. When I used to work with Lisa and the gang and Nadine at 8 Rinks, it was great because you'd have an athlete at stage 1 that's looking across at all these other athletes far along in the process, and it's really important for them to understand that the process begins with the end in sight, and that the work that they put in at this very early level will pay dividends when they do get to those later stages. So even at this stage, the priorities are to establish or reestablish the body extremity position and alignment, that we establish or reestablish muscle, proper muscle recruitment or timing, especially of the stabilizing muscles, that we again establish or reestablish the proper movement strategy, and that we progress the endurance of all these stabilizing muscles. So this is crystallized into 3 keys that every athlete must remember and establish during any exercise, and quite honestly, I'll leave this and hammer home this point. If the athlete takes nothing else away, they remember these 3 things, which is position, establish good position. If you don't, you're working from a deficit. Proper muscle sequence, especially in this particular area. We know all the good research that tells us that things are inhibited, that muscle timing has changed, that there's inhibition and changes in recruitment patterns. And then this movement strategy that we just validated in the preceding studies. So again, we come back to this importance of strategy. There's no guarantee that our Swiss ball exercise that we do in the clinic are transferred to the field of play. So again, the importance of a strategy. We know that a skill, the ability for a skill to be transferred to another environment is small but positive, but it's improved if we can increase that deeper level of processing that we talked about, that motor, sensory, perceptual, environmental cognition. So these are just some examples of common faults that we all recognize and see, and just happen to be allocated to these different areas of biomechanical, neuromuscular, and movement strategies as sort of global areas. Some of the examples of common faults biomechanically, decreased hip and knee flexion angles that we just talked about, increased lumbar lordosis and anterior pelvic tilt, and making sure that as they correct that, they don't start to scoop and overcorrect, which I see quite often when I send the athletes away with their homework and a DVD, and they come back and they think that they want to sort of impress, and they're so proud of how well they're moving because they don't break into that lordotic posture anymore, and they come in and show me that silly scoop. In the frontal plane, typical sort of valgus load or unloading of the injured leg. Again, these are all things that can be started and addressed and evaluated early in the process. I'm going to play again a video that again just demonstrates from the very initial sequencing, position. Right away, we're sort of kicking out the flexor pattern, got this athlete into dorsiflexion, pushing away with the heel so that the hamstrings aren't firing, and the hip flexors are inhibited, and then again, resisting abductors, adductors, closing the chain, working diagonal patterns with the Corex. There's your plug, Dale, Corex. Corex. And again, working diagonal, simple diagonal patterns. Working the hip, proprioceptively and with rhythmic stabilizations in that centralized position, in an extended position, demonstrating this classic sort of break pattern into that right extension quadrant. And again, rhythmic stabilizations, but first, again, making sure that they've got position, proper muscle sequence, and where they're resisting from, so that movement strategy. And even here, we're getting, more sport-specific, working rotational patterns to bias to transversus. Again, working rotation, making sure that they get that pelvis around like we demonstrated in that first video. Getting more dynamic, where now they have a number of different variables to control at the same time. And again, this counter rotation. And again, this is just sort of a proprioceptive hip drill. So the video obviously progresses beyond stage 1, with stage 2 involving a progression into the increasingly dynamic, complex, and sport-specific movements. And these, this is where as they get more dynamic and sport-specific, we can start to address some of the injury mechanisms, some of the natures of the sport, and even the position within the sport. And again, that becomes very motivating for the athlete. So rather than doing sort of a generic exercise that the tennis player and the football player and the figure skater are all working on, that it becomes very relevant to what they need to get back to. So you can see here, and again, you're only limited by your creativeness in terms of the drills you can, but it still comes back to reinforcing those fundamentals or those basics. So to briefly explain the goofy tubes, and again, I know a lot of you have heard this a number of different times. For those that don't and haven't heard of our use of this TheraBand, this was actually Alex McKechnie, a colleague and sort of partner of mine that initially developed this back in 1996, 97, and then since we've kind of come up with a more user-friendly version in terms of the Corex. But we found it useful for two reasons with these particular issues or injuries. One is that it seemed to create a pain-free environment for us for the athlete to work in, and two, it assisted us in reteaching the movement. So what we think it does, quite simply, is increase the afferent input to the body, and perhaps in an open chain environment, create this sort of pseudo closed chain. That may increase co-contraction and may just simply improve the proprioceptive or the kinesthetic sense. So again, we don't know why it works, but it works, and I've even played around with a little bit of EMG work in the lab while I was waiting for subjects, etc. When we talk about the transitioning of the clinic back into the sport environment, this is a skier, and again, I apologize to those that have seen this before, but again, this to me is I didn't tell him to put the tubes on when he went to Europe to train. He had a rotational instability at L4-5, and he took it upon himself to, as in his words, the first couple of runs on the hill, he just didn't feel like he was transferring what he'd done in the clinic to the hill, and he felt like with the bands on, it connected his upper and lower body, and he felt like he was sort of one. He felt like he was connected through here. So it's a little bit tougher on the ice to have the Corex on. I've tried it. It's, blades, sharp blades and elastic bands and stand back. But here you can see the application into a more sport-specific environment. Here we're obviously, again, progressing the rehab of this knee, this hip, with rhythmic stabilizations with varying degrees of demand on the ice. Here, I'm water skiing behind them, and I actually do this on the soccer field with the Whitecap guys as well, and I'm basically constantly resisting them manually to fire through this area so that it's overloaded, it's overemphasized in terms of its recruitment. And here, again, it looks like I'm water skiing behind him, but I'm actually, it's purposeful in that I'm trying to not let him open up on that right side of his pelvis, so he's got to keep that compact. And what's fascinating is that a lot of the guys that do sort of spin open, they have these groin or these adductor or labral tears. When you do that and they stay compact, they can skate pain free. Whereas if you just let them go, they describe pain, especially at the end range as they open up and extend. Just right at the pelvis, right at, yeah. So that's the value of the hockey stick. I was just hanging on to it. So obviously, again, the final stage involves integration of all these acquired movements back into the sport. This is really important, and again, it's so evident, especially in a group like the Whitecaps and with the soccer players who have to perform things for 90 minutes, and most of these injuries happen near the end of the first half or near the end of the game, when if you don't have the energy systems, your aerobic and your anaerobic systems intact, it doesn't matter, again, in your little bubble how well they're moving. If they can't perform those tasks, with all kinds of distractions in a fatigue state, that's, again, where I think we quite often don't complete the process in terms of our rehab and I'm using obviously athletes here, but you could relay this to or relate this to all kinds of occupations that are sort of high demand, high physically demanding, or high cognitively demanding, where they may be exposed to injury. Obviously, our functional tests provide us sort of the quantitative indicators. Oh, sorry. Go back to that. Obviously ensuring that we have some quantitative measures of where they're at, and identifying and addressing any potential psychological barriers is part of this process. So the end stage of the rehab process should not only recreate, but in many ways exceed the demands of the sport. This is a video that Owen Hargraves, as he was working with Alex this summer, posted himself on YouTube, and it's I think just a fantastic example, or a couple examples here, of the level of drills that are required at the highest level. Okay, so again, you can see if those movement strategies haven't been reinforced right from day one, when the demands are to that extent, or when he's having to react to different numbers or different sort of cues, then that has to be an automatic response. That they consistently, male or female, doesn't matter what the sport is that they consistently put themselves in a position that they can respond to this unpredictable environment. That's really what we're trying to create here. Still going to have injuries. There's no getting away from that. But if they can consistently move in such a way that the risk is less. It's William Garrett, an orthopedic surgeon in North Carolina, and I love this. He's coined the phrase "the perfect storm." And I look by. There's a video on Global TV. It's the first time in, I guess, almost 20 years, 18 years that I've seen my first ACL injury. It was on TV, and I mean, it's funny how the mind plays with you and sort of distorts it. But it's absolutely critical that you have a process. I look at that particular injury, and if I'd just been perhaps prepared myself a little bit better, or just done a little bit extra in terms of pushing off or getting in a better position, you break that perfect storm that results in an ACL injury. So if you have a little bit more knee flexion, if you have a little bit less abduction, one of those small adjustments might be the difference between the ligament going or you just sort of crumbling. Here's another drill, just a rotational drill. And again, this is actually the easy part. This is the fun part with these athletes when they get to this level. In terms of a 12-week process where you've got 4 weeks in that first stage, 4 weeks in the second stage, and 4 weeks in the third stage. This is the easy part, not for them. For us, I mean, it's quite taxing for them. But once they've established that, then it's really kind of neat to see even sort of video of them performing their sports before and after, and seeing what a 12-week process does to their strategies. So, in summary, a well-designed rehab program is one that is systematic and progressive in terms of its structure and evaluation, but flexible, as we've outlined here in terms of the content and the timelines. Obviously, it respects the stages of healing. It emphasizes this quality of movement and integrates the function throughout the entire process. We must optimize the potential for these skills and the movements that are gained in the clinic to be transferred to the field of play. And really, the process isn't complete with the demands often exceeding that of the competition. And again, I'm going to play this video for some of you. You're saying, "Are you kidding me? You're going to show this video again?" But it really, even with patients that are kind of at the 12-week mark, it's a good one to sort of show things from start to finish in terms of the principles and the different stages. Here again, we're starting in a very low level state. We've closed the chain above and below. Increased recruitment through the adductors and closing the chain through the upper body, just to again give that even additional afferent input. A lot of these guys, they're high-level athletes, but they cannot recruit, they cannot initiate the movement from the middle. And as we go through this, you'll notice that every one of these particular movements are rotational. It's important that we address things in the sagittal plane, in the coronal plane, and obviously in the transverse plane, and in multiple planes of movement. So again, just rhythmic stabilizations. Here's a player that had a pelvic instability. Again, initiating that movement from the middle on a core board. Dissociating the upper body from the lower body. You can see here we've learned from then, to me he's too vertical, knee flexion and hip flexion angles aren't nearly what they should be. Don't tell him. So getting more sport specific. And again, if you think this is an easy drill, just look at his face. This is again all core. He's initiating the movement from the middle. This is again rotation. And again, if he doesn't lead, especially coming back, if he doesn't push off that front leg, he winds up extending and landing in sort of an extended position through his lumbar spine and anteriorly rotated through his pelvis. So it's again keeping that lumbopelvic hip neutral by the push off, by the strategy of movement. And very, very critical is performing these drills, for example, on the side of the court or on the side of the soccer field, and then directly applying them to the sport, so that there's that transference, and then coming back and cleaning them up on the side of the field of play, and again reintroducing them to the sport. This particular set of drills was really all trying to accomplish the same thing, which is getting him to get this left foot around and get his pelvis square to the hoop, so that he had a consistent, solid base to work from in terms of this fine motor control that he has with his shot and his upper extremity and the release. And the more predictable, the more stable and consistent his plant is as he comes around on that left side, the easier it is to make that shot. Here we get rid of all the bands and the gimmicks. And here again, resisting them concentrically and eccentrically. And again, his variability to practice is getting at the same outcome with so many different ways. So again, you're not learning a movement pattern. In fact, you don't want them just to get good at a movement pattern. You want them to apply the strategy over and over. And this is what it's about. All those drills were for this particular shot, cutting from the right, cutting to his left, and spinning around and getting square to the hoop, and being solid through that lumbopelvic hip area. So, like I said, and I apologize for those of you that saw that latter part a number of times, but again, I think a couple things. One, things haven't really changed in 16 years of doing this, which is encouraging. Two, it's also a little depressing. But two, the validation of it, to some extent in terms of the research, like I said, was a rewarding aspect of things, and I think, more than anything, it has practical application, and I think that's the most valuable part of the takeaway, is that it has practical application. And although it seems maybe on the surface to be complex, like most things, as you refine it, as you develop it, it becomes more and more simple. And that's really, hopefully, the essence of this, is that this, along with other techniques, whether we're talking about a young female soccer team or an athlete trying to rehab from one of these chronic recalcitrant conditions, it's the same instruction, and at least we have some understanding of the effectiveness of this in providing that. One has to understand whether it's a healthy athlete that you're trying to prevent injuries from, or whether it's an injured athlete that is ingrained in this habitual pattern. You need some sort of catalyst to change how they're moving, to change their strategy. And this is but one effective catalyst or technique to break that pattern of movement. So I'll leave it there and open it up to questions. So thank you for your time.
Like the video with Steve Nash. Did he have a particular complaint that he came and saw you with, or did he look to me as a physio, as a sports performance, sports science end of the spectrum, rather than I've got an injury or a complaint? I would have thought the sports coach or the strength and conditioning coach might have taken some of that role rather than a physio.
Yeah, I mean, I guess it depends on, it's kind of know what you don't know, and I certainly think that the scope of our profession lends itself to the addressment of injury prevention components of, there is obviously a blurring of the lines, but in this particular situation, to answer your question more directly, there was a recurrent issue that's kind of been well documented both in his back and his pelvis, that as you see that movement, and I call it sort of an outrigger with a lot of, and what I tell a lot of these male professional athletes, a lot of times they're moving like young female soccer players or young female athletes in terms of getting that outrigger position and using the inert structures, the skeletal and the ligamentous system to stabilize. So it becomes sort of this hard, heavy sort of stop that is stressful, as we know, as I sort of demonstrated. So I think, ideally, if we can, at the very least, be part of that transition back to the performance aspect where we know that they're moving well, then it is an appropriate handoff to the sports science or the sport performance coach.
So for him, who picked up on that problem with the turn? Is that you as the physio?
Yeah. We sort of worked on things from a rehab or a treatment perspective, and then we really needed to know, so why is this happening all the time, one, and two, what aspects of his performance is something I ask every single athlete that comes in. And I'm not a performance guy. I don't train guys. Guys that ask me, I don't do that. But every athlete that I work with, after we've gone through the whole history of when does it bother you and how did it happen, etc., is what performance limitations do you find? Quite often, hip labral tear. They'll tell you I can't cross over to my left if it's a left hip labral tear. So those are kinds of things that you have to understand, and they'll say, yeah. I'll even sort of preempt it sometimes now and say, do you have a tough time kind of when a guy sort of cuts, to this side of you? So, good question though. So the first question is video feedback effective? Absolutely, and that's where, again, there have been effective studies to demonstrate the effectiveness of reteaching. There's a Dempsey, a group of researchers in Australia that demonstrated with a number of male athletes the side cutting movement with video feedback. So it's individualized and with video feedback. But again, the key difference within our study was that we had coaches deliver it in a team environment during a warm-up where they didn't have the value of all those things. In a clinic, completely different. The first thing I did when I started this gig with the Whitecaps was put mirrors up in the training room at BC Place and at our training facility, because I can't work without them seeing what I'm telling them they're seeing. So that's first and foremost. And that is, I've structured my answer much like your question, in that the follow-up to that is the fact that if they're seeing it, there's again, going back to the muscle or the position and the muscle sequence, if they detect failure either in position, and you're right in that even the most gifted or elite athletes, the way they move is normal to them, and they don't necessarily perceive that as being dysfunctional until, like you said, you demonstrate it. So once they see it in the mirror, once you challenge it and demonstrate that they're not loading it the same as the other leg, etc., then they can recognize that and have that constant feedback visually. The iPad, I use an iPad as well, and I think it's even more beneficial, and especially if you're out in a field-based setting. But no, great questions, and I think that's. I would definitely encourage, and I use it all the time, visual, showing them what they're doing, let them see what they're doing, all those, very effective techniques. But like I said, the important thing is that we have some, even if it's a gross mechanism of coaches, being able to say, well, you know what, that center mass, their belly button, or that ball in the middle here, is not moving. That it doesn't look right, but at least I can tell them, I can monitor that, and I can tell them that. Another question? We don't know what aspects of those programs. They're great because they're comprehensive, but because they're comprehensive, we don't know what the active ingredients in there are. So if we don't know that, it's up to research to try to tease that out so that we can be more, again, realizing that compliance is an issue for coaches, for athletes, and we want to crystallize what is the most bang for your buck. If you had to do balance or strength or technique, or where is your energy most effectively directed? As it stands right now, what I would recommend is do a comprehensive program like that, have methods of improving technique, and the core pack being one method of instructing them. If and part of the rationale for this is that some of the conventional instructions, like keep your knee over your toe and bend your knee more, those seem like very obvious ones, but as we all know, in terms of complex movements, if any of us have tried to learn the golf at a late age, and we're told to sort of cock the wrist, straighten the elbow, straighten the knee, bend your back, that focus internally on sort of segments for complex whole body movements isn't that effective. So this is one way, again, it's a single focus of attention that if done properly, seems to allow all those things. The foot doesn't turn out, the knee doesn't, or the knee bends more, the knee doesn't collapse in. So it just encourages that to happen. Plus, it's creating an increase in activity, which it would have been nice to support this further with some EMG studies to show increased activation of those core muscles as we're landing. So the first thing I would do is, again, come back to those three key elements is position. So if they're starting in that sort of valgus position, stationary, so they're in this athletic neutral, as we call it, sort of a defensive stance in basketball or soccer, it's just a real functional position, sort of that semi-squat position, is to see, is their foot rotated outwards, is there, do they have good bend in their hips and their knees, are their knees aligned? So that's the start. Second is the muscle sequence, to make sure that they have recruitment. Again, Tim Hewitt did some great prospective studies looking at that, the delays and the dysfunction of some of those key stabilizing core muscles being predictive of ACL injuries, especially in these young female athletes. So prophylactically, let's get them to increase that recruitment through there. And then thirdly is the movement strategy is to make sure that if I can, I'm mobile here. If I can come out here, it's rather than even something as simple as a lateral shuttle, or let's put it this way: if at the end of a set of doggies for fitness, we've all seen this before, they start going like this and they start sort of reaching for that last, couple, or even a lateral sort of shuffle drill where they don't, I have this debate, we'll call it a debate with the basketball coaches all the time, where they want these big men to come into this deep sort of position and they want them to always lead with this leg. Well, first of all, it's inefficient because you're decelerating every time. Secondly, by driving off this leg, you'll see the sort of difference. If I lead with this leg, this gets sloppy and noisy and it's disjointed, versus if I drive off this leg and this one follows, I'm leading with the center mass, I'm driving into the ground. And, again, aesthetically, we can all see the difference in terms of the quiet, the control, the maintenance of that neutral position. So it's those three things. It's getting them into a good position to start. Today, watching the weightlifting session with the Whitecaps, there's some guys, they're loading up, the squat rack, and right off the rattle, they're starting here. They're working from a deficit right away. At the very least, they're compounding what their dysfunction is. And then it's the recruitment, and then it's always the movement strategy.
How do you describe that to those young girls, though? Demo it?
Yeah, absolutely.
Okay.
Yeah, absolutely. And then I'll, even with the Whitecaps, they're not much better, some of them, and it's given them understandings like, for a soccer player, or a baseball player. If you see somebody that's never kicked a soccer ball before, they'll work from that distal to proximal movement. They'll sort of lead with their foot. Whereas you see sort of an accomplished soccer player, and they'll initiate the movement from here, and it'll be sort of this ping, this real sort of same thing, sort of throwing, rather than this sort of, it'll be a whole body, and you're creating the power from here. Randy Johnson, in his book, apparently, one of my athletes told me, I've not read his book, but he described how he would save his shoulder by making sure that when he finished a throw, those of you guys that remember Randy Johnson, he'd make sure that his belly button was facing home plate, so that he was getting the power from here. And as some of you have seen some of my other presentations, I go into more depth into this in terms of summation of speed principle and Bunn's principle, etc. And there's good performance evidence of this. But this is even talking to martial artists, and this is where they develop their power from so many different levels. It's supported. It just hasn't been necessarily applied in this particular application. So does that answer your question? So it comes down to I'll demonstrate and explain to them, and even in terms of their particular nuances. I mean, they may have a valgus collapse. They might be sort of what I see with a lot of these hip labral issues is that they actually load on that lateral aspect of the foot. So that's a completely different hockey player I saw yesterday was getting him to see that and identify that and making sure that for him, it wasn't so much that he's collapsing into that valgus. I want him actually to increase that medial load. So position, muscle sequence, movement strategy with every single one of them, start to finish.
Frequency-wise, you were saying 12 weeks, and how often do you usually see that?
With these particular, it varies. It varies on a lot of different things. If they're flying in from out of town, we'll quite often, at the very minimum, I'll sort of want them to commit to 3 to 5 days, doing 2-a-days for an hour and a half to 2 hours, and get them back in at the very minimum 3, probably more like 4 times during that 12-week period.
The first drill that you get the girls after you've demonstrated how to do it, do you just get them to do like lateral hops?
Yeah, you know what? Again, I think maybe that's what you were saying too, Andrea. So the question was, what do you start with? First of all, I'll just get them just to drop into this position, and then coming up out of with this, this focus in terms of control, and then just get them to do a lateral step, just here, and then get them to do, sort of just a lunge up and down, and then getting to do a lunge from here and pushing off and coming through. Again, if you sort of look at it from the sagittal plane, if I don't get a good push off of this leg coming through, I've got to reach, and now I'm exposed. If I don't get a good push off back, it's even worse because I'm caught here. Now I've got to come back here, and I'm landing in an extended vulnerable position and an unbalanced position. I mean, again, everything comes back to being balanced. If you're in this sort of stride position, you should be able to be here and equal weight on both legs. It's really in a multi-directional, unpredictable environment, it gives you the best chance to succeed as if you can go either way if you haven't committed to one side or the other. So everything you can do to reinforce that is a potential benefit.
So my impression of the program is designed so that eventually coaches can teach the kids to do this.
Yeah, that's,
It's a long way
yeah.
ahead.
No, I think, Andrew, that to me is, what one of my professional ambitions is doing is to influence, obviously, especially locally here in our Lower Mainland, is injury prevention programs. And like I said, I want to make sure that I don't overextend, what this is capable of. Again, to me, it's one tool in terms of movement technique that could be a catalyst to change some of these ingrained patterns that would otherwise, if you told them just to bend their knees more and get their knees over their toes, they just can't, they can't process that. So to me, it is, as we've sort of demonstrated, an effective tool. Like I said, clinically, it's been money for 16 years. But in terms of that transference to the coaches and the groups that we worked in, I mean, what I didn't present there, but was within my dissertation, was even talking to the coaches and all the athletes. I mean, it was something that they saw that was practical, that, it wasn't sort of some artificial, this is kind of cool, but we won't use it after this, and that was really important to me. I don't know that they're going to use those styrofoam balls. That was sort of a way of demonstrating and really illustrating it in there, but I can't see them running around with these styrofoam balls over their belly buttons.
Well, loved it. So thanks so much for coming for us.
Thank you, guys. Thanks for making the time.